So yeah, I just want to welcome you all to our final session of the Africa stream of the Shifting Narrative Conference on Public Services, Public Spending and Provision. So yeah, it has been really exciting so far, like the last few days and also today in the Africa stream. My name is Vera Wegmann. I'm a research fellow at CSIRO at the University of Greenwich. Together with UCL, we are co-organizing this conference, but not alone, but with many amazing partners. They're listed above me, you can see, and one of which is the University of Ghana. And I'm very, very happy to be here with all of you guys and Professor Nana Akua Anyidoho. I hope I pronounced your name correctly, more or less, from the University of Ghana will be our facilitator today. So I just hand over to Nana, who will take care of everything. If you have any other question about the organization of the conference, please let me know in the chat. I will monitor the chat. And otherwise, we will have first really exciting presentations and then Q&A. Thank you, everybody.
Thank you. Thank you so much, Vera. And I'm very happy to be able to facilitate this section on healthcare. I think that the notes that was put in the program about the importance of this particular it's very apt, and so I'd just like to repeat it. I'm sure some of you've seen it, but just in case. So like education, campaigns for universal public health care have been led to movements and international NGOs in many countries simultaneously, with academics from the global north repeatedly partnering with local researchers to identify key problems, not only to identify, but also obviously to advocate, to do policy advocacy, and in other ways to enact activism to let these healthcare strategies be taken up by policymakers. So it's great that we have a combined force, a combined panel of both policy advocates, activists, and academics. This is the kind of partnership that we need to see more of, and I'm really pleased that this conference is bringing us all together in this way. We have a lineup of 5 speakers from different campaigns. Vera, if you'll help me out, and if there's somebody who is not here, perhaps you alert me by the chat, but I'm going to assume that everybody is present and accounted for, and we are going to go in the fantastic. We're going to go in the order listed in the program, and we are going to take 15 minutes each so that we'll have enough time for the animated discussion that will follow the presentations. I'll introduce each speaker as they come up to speak. So for now, I'd like to give you a short bio of Nicholas Orago at the University of Kenya, who is speaking on healthcare in Africa. Dr. Nicholas Orago is a passionate and committed human rights advocate. His main area of specialty is economic and social rights. The focus area of his doctoral studies and an area of research where he has published several journal articles and book chapters. He's taught, trained, and consulted extensively in this area of human rights advocacy and specifically in economic and social rights, as well as in related areas of international human rights law. He also has research interest in climate change, disaster law, and sustainable development. He served as a Marie Curie Research Fellow at the University College of Cork, UCC, Ireland. Seconded to the International Federation of the Red Cross and Red Crescent Societies in Geneva and Switzerland. This is just a brief summary of his expertise and his involvement both in academic research as well as in policy work. So Dr. Orago, you have 15 minutes and please take it away.
Okay, thank you so much for the introduction. I was given the responsibility to look at healthcare in Africa, which was quite broad if you look at the breadth of the African continent, as well as the many countries that we have. Just a correction, I'm from the University of Nairobi, not the University of Kenya, as has been stated, the School of Law. So I'll go quite quickly to my presentation. I'm looking at healthcare in Africa generally. So it's to not be very, very specific to any particular country, but of course I'll touch on Kenya, where I have done research. So good health is a precondition for both personal, human, and socioeconomic development. And it's very critical that if you're going to have good health for your population, you have to have effective and accessible healthcare systems that will help you to achieve good health and will enable you to achieve sustainable personal, human, and socioeconomic development. In the context of Africa, we have not quite enjoyed very robust health systems. And this shows in the minimal improvement in our health outcomes. For example, in the last 50 years of independence, we haven't grown much in terms of our ability to be able to make people enjoy substantively how do I minimize this so that I'm able to see my slides?
We can see your slide if this is your question.
I'm looking at how to minimize the.
Oh, no, we can't see that either. Sorry,
Okay.
but we can see the slide perfectly.
Okay, so if you look at Africa, despite the improvements that we have in life expectancy, where we have improved from 58 years in the 1950s to about 63 years for men and 66 years for women, we still have a long way to go to achieve the global life expectancy of 73 years. And this is because of the current challenges that we still face in the context of Africa. Our healthcare systems have grossly underfunded in terms of ability of governments to put in place the necessary funding to achieve the kind of effective healthcare systems that would enable each and every person to realize their fundamental right to health. We have extremely overstretched healthcare systems, which is grossly understaffed. If you look at in comparative perspective, only 2 doctors per 10,000 people in Africa in comparative perspective, only 11 nurses as compared to 28 globally in the context of what we need to be able to substantively ensure that people enjoy or have effective access to healthcare. If you look at the general human resources, we are grossly understaffed. Almost 1.5 million skilled workers are lacking to enable African health systems to be effective. And the African health system still faces a lot of challenges in terms of the need to address the very, very substantive disease burden that we have. We still account for over 23% of the global disease burden. And we still struggle with the traditional communicable diseases like HIV, AIDS, tuberculosis, and malaria. We still struggle with social determinants of health, like nutrition, not only for adults, but also for children, with nutritional deficiencies like malnutrition and undernutrition leading to high infant mortality rates. We are not on course substantively to achieve the SDGs in relation to child mortality. And as we struggle with the communicable diseases, we are also struggling with the non-communicable diseases, with the cardiovascular diseases, diabetes, cancer, being challenges that are still faced by many African countries. We also have challenges of equity in access and use of the healthcare infrastructure in the context of the physical availability of the infrastructure. we do not have sufficient or substantive investment in healthcare to enhance access for the majority of the population, especially if you look at the reality of rural areas that do not have sufficient health infrastructure, and people have to walk substantive distances in order to get access to healthcare, which in most instances is understaffed, overstretched, poorly capacitated, and does not have the necessary pharmaceuticals in order for it to provide substantive healthcare to the population. We also have challenges with economic affordability of healthcare. And in the context of the discussions that we've had already in relation to water and in relation to education, the challenges of privatization of healthcare is also a challenge that Africa still faces, which increases the costs of access to healthcare by almost 12 times what is paid in public hospitals, making access to healthcare quite a challenge for the majority of the people. We also have challenges with cultural acceptability in relation to people's being treated fairly and properly in health facilities, which in essence makes many people, especially the minority groups, to stay away from the formal healthcare system. So we have a poor value for money. We have inadequate frameworks being in place for regulation to ensure quality and to ensure that people have received a value for money in terms of the costs and the services that are offered in the healthcare systems. Then we have challenges of quality service delivery, effective integration of health systems, curative and preventive, with the focus mostly on curative and very little focus on those social determinants of health that determine prevention of healthcare. Then we have a challenge of sustainability of financing that will be discussed, of course, in the context of the panel, where governments still do not provide adequate financing, adequate direct budgetary financing to the healthcare, despite there being declarations and legal instruments that requires a certain percentage, 15% if you look at their budget declaration. But you still find that 2/3 of our healthcare is still funded by private expenditure. And this is because of lack of political will, political support, and political commitment for an effective public health healthcare system. So if you look, for example, at the data that we have, you see that in most of African countries, the substantive financing in the context of healthcare is still private, with the majority being out-of-pocket expenditure, which means that for the majority of the people, they are almost only one disease away from poverty. And if you look substantively at countries that have been able to put out sufficiently substantive expenditure into their health systems, you only look at Gabon, South Africa, Mauritius, and maybe, which is the other country, Mauritius, that have put in place sufficient public financing to be able to support their healthcare infrastructure. So we have several barriers to positive health outcomes in Africa. If you look generally, one of the challenges is poverty, where we have socioeconomic diversity in relation to the high income sectors of society who are able to afford healthcare on the basis of either insurance or on the basis of ability to pay, while you have the low income sectors of society that do not have the capacity to access healthcare or are engaged in catastrophic expenditure in the context of over 40% of their income going into healthcare. Then you have spatial diversity in terms of rural-urban, where rural sectors do not have sufficient infrastructure for healthcare, while urban sectors also have that challenge in the context of the informal settlements and the formal settlements, where the formal settlements might have access to health infrastructure, but the informal settlements do not have access to health infrastructure. Then you have cultural diversity with the majority communities having access, where the minority communities do not have access. The next challenge that we have in Africa is demographic pressure. We're having a fertility rate of about 4%, where we have the population quite increasing rapidly. We have a youth bulge that needs health infrastructure, especially reproductive health. And we also have an aging population with the increasing life expectancy that also requires substantive access to healthcare. We have poor governance and corruption in many of our countries that makes it almost impossible to sustainably finance the healthcare infrastructure and the system generally. We have challenges of climate change and its impact. We have food and water insecurity that has affected, or that is bound to substantially affect livelihoods. And this is going to affect the ability of people, especially those who rely on out-of-pocket for healthcare, to be able to pay. And also in the context of food and water insecurity, if you look at the social determinants of health, good nutrition, access to safe drinking water, the challenges that will be substantively be introduced as a result of climate change. We have the extreme weather events resulting from climate change, droughts, floods, and if you look at the exposure that most of African countries, especially the poor sections of the African countries, vis-a-vis their capabilities for adaptation and mitigation, which in a sense is going to expose more and more people to calamities that would require healthcare, access to healthcare systems in the context where we do not have sufficient financing, public financing of public infrastructure to enhance access to healthcare. We have, due to warming, pest and disease vectors gaining more in terms of places and places that experience certain vectors that they did not experience before. And that, in essence, also creates challenges in our ability and the ability of our healthcare system to actually hold on and be able to provide healthcare for each and every person. We have air pollution, which is related to climate change in the context of just energy transition, and exposure to air pollution that leads to ill health. If you look at the majority of the African population and access to energy, you still have wood fuel and charcoal as being the substantive source of energy, which causes, of course, smoke, which affects people's health and leads to the death of about 1.6 to 3 million children annually. And if you're looking at this in the context of energy transition, the ability of the African continent to be able to achieve just energy transition, and if there are failures, the adverse outcomes to health that is going to cause. Then we have rapid and planned urbanization with substandard housing, lack of water and sanitation, issues of poverty, unemployment that makes it difficult for people to have access to safe places of stay and access to water that would determine health, preventive health generally. We have issues of conflict and the reliance on declining donor funding that are challenges that we face on almost a daily basis. So which way for better healthcare in Africa? We need to think substantively and put in place holistic approaches to improve our healthcare systems by promoting or enhancing integration of promotive, preventive, and wellness into curative, so that we have a substantive integrated system that looks into the entire health system, not just curative healthcare, but also preventive and promotive healthcare. Then we have issues of equity and accessibility in the context of budgets, ability of people to have access to healthcare, social security, health insurance, and also the need for cooperation and participation of all stakeholders in order to ensure that the healthcare system is inclusive and effective. These adverse conditions have been worsened by the COVID-19 pandemic, we have seen that Africa has relied on external financing, but we have seen that this external financing has not been possible because of the death of global solidarity with countries holding PPEs, ventilators, and vaccines. And this has led to, how much more minutes do I have?
None at all, actually. You've done 50, if you can wrap up for us, thank you.
2 minutes, yes. So we have seen the challenge of COVID-19 inability of Africa to vaccinate its people, and the challenges of possible new variants that would lead to exclusion of Africa in the international community. So if you look at the challenge of privatization that have been discussed substantively in relation to water and education, we also have the problem of privatization in the context of healthcare. Many countries are taking healthcare as a right, entrenching healthcare into their constitution, and putting in place universal health coverages as policies that they need to put in place, but they're also putting in place policies for the privatization of healthcare. So how do you enhance access to healthcare, ensure that everybody has access to healthcare? What is needed in this context is that we need to prioritize investment in the public health system in terms of financing, in terms of human resources, in terms of technology, and in terms of pharmaceuticals. The private sector has a role, and it can have a role to supplement what the public healthcare framework has. But in order for it to be able to achieve this, there has to be effective and transparent accreditation regulation frameworks to be put in place. And there also needs to be involvement of people and information sharing to address information asymmetry to ensure that the healthcare framework is actually subject to democratic control. Thank you so much.
Thank you. Thank you, Dr. Orago. As I mentioned in the chat, he can't stay till the end when we hope to have a discussion on all of the papers. So we are going to have a few minutes where questions specific to his paper can be asked and answered. So do we have any questions? As I mentioned in the chat, you can put your questions in text, or you can raise your hand. And then we will call on you. I see we have a hand up here. Sorry, I can't see the full name. So Al-hassan Adam. Okay. Yes, yeah. Hi.
Thank you. That's a really exciting kind of presentation, and looking at the overview and what's happening and stuff. What's your take on the role of churches in health delivery? I know, like, in certain situations, they are really kind of key, especially in rural communities. What's your work around that? What have you seen?
Thank you for that question. Yes, churches contribute to healthcare, especially in the rural areas. But also healthcare institutions are facing the same challenge of financing as the other health infrastructure is facing. And they're not as many as the private for-profit providers of healthcare. As if you look in the context of Kenya, for example, for-profit healthcare providers provide 40% of healthcare currently. And churches and NGOs provide about 22%. So yes, it's critical, the service that they provide, but they're not providing it at a level or at a scale that can make a substantive difference to the healthcare infrastructure generally. And also, they also have the challenges, as I've said, of access to medicines because of infrastructure that is just not functional, especially in the context of pharmaceuticals. So they play an important role, but also need the support that we are talking about in the context of the public healthcare system.
Okay, thank you. This is not exactly a question, but Mansoor Sharni in the chat just made a comment reflecting on what's happening in Tunisia. He says in the past 20 years, Tunisia has constructed 2 public hospitals, but about 20 private clinics. So this creates sort of a dual system where you have, you know, good medical care for rich people, and then poor people have to go on another track. And he just wants to comment that, you know, healthcare is obviously not a commodity, but a public good. So that's just a reflection on your presentation. Are there any other questions or comments related to Dr. Orago's presentation? Okay. If not, then I would like to thank Nicholas again. Thank you. This actually we do. So Anna Mariott, yes, please go ahead. And then after that, Linda Oduonwa can speak.
Thank you, and thank you for taking on that almost impossible task of providing the overview of healthcare in Africa. You mentioned near the end there on your slide around the role of the private sector, that you think that the private sector does have a role but requires regulation, accountability, and clear conditions in place. I've just literally come from the Asia group that was talking about the privatization trends in Asia and the challenge of regulation, the challenge of, with a proliferating private sector, how the power dynamic changes and there becomes corruption and a link between public and private that ends up being quite unhealthy. And I just wondered whether you think that it is indeed possible to regulate the private sector when the public sector is so weak, and whether actually it's incredibly difficult to do that unless you have a strong public alternative for people to go to, so that it actually becomes a choice to go to the private sector rather than a necessity. Yeah, just interested in what you think about that power play between public and private and whether it is possible to actually regulate.
Okay, the first thing I said that the priority is actually investment in the public sector, both in terms of infrastructure, in terms of governance, in terms of staff, and also in terms of technology. And this is critical to ensure that the public sector works effectively and is able to provide the necessary care that is required by the majority of the population. My context in terms of the private sector is just to complement what the public sector is providing. And the reality that we have seen is that the private sector has proliferated in the healthcare infrastructure, supported by government, supported by the international community. And this is unhealthy because there has been general neglect in the financing of the public sector. So the priority, if we are to achieve universal health coverage, the priority, if we had to treat healthcare as a right, is to invest in the public healthcare system, so that the majority of the population can actually have access to the public healthcare system. And if we have to have a private healthcare system, then it has to be effectively regulated. The challenges of regulation is a discussion for another day. I understand the challenges that come with regulation of the private sector in a weak governance institution and framework. And most of our African countries are quite weak if you compare with the multinational companies that support private healthcare. So it's a difficult conversation that we need to have, but we need to have it if we are going to ensure that at the moment and with the challenges that we have, people at least have access to quality, and they also are not substantively exploited in relation to costs.
Okay, thank you. I'm going to ask Linda and then Baba to ask their questions one after the other, and then if Nicholas can try and give a quick answer to them so that we can have the other speakers also. So Linda and then Baba, please go ahead.
Okay, thank you, Nana, and thank you, Dr. Orago, for your presentation. So my question is related to Anna's question about regulation, but more from the perspective of international financial institutions that have been investing in a lot of these private hospitals in Africa. What would you say, or what would be your ask to them in terms of improving their accountability frameworks, where the behavior or provision of services by private actors that they invest in? What would you ask them to do in terms of strengthening their own accountability frameworks so that these hospitals are held accountable for the impact that they have?
Okay, thank you. That's a difficult question.
Can I have Baba also ask this question so you can answer both of them together? Because we have
thank you. And I'll be quick with time. My question dwells more on the place of health insurance companies and health insurance funds, and how these contribute to hemorrhaging resources from public delivery on one hand, and also contribute significantly to two-tiered health inequities, in short, in different ways. Because a few years back, a member of parliament in Kenya pointed out that, on average, you had private hospitals getting like 9 times what public hospitals got from the National Health Fund. In South Africa, the National Health Insurance Bill, you see, it's quite clearly leading to deepening of health inequities, as PSR pointed out time and again with the medical aid scheme, which are, so my question, because part of the argument is, inadequate resources and what have you, but health insurance is being used to, along with funding from international bodies, IFCs and what have you, to how what alternatives to the model of health insurance now could be looked into, including drawing examples from taxations like with the NHS in the EU. How can we get leaders in Africa to change the model now that essentially it amounts to getting private hospitals better enabled, more than actually contributing to addressing the funding question for public healthcare delivery? Over.
Thank you so much. Let me start with Baba's. It's actually lack of political will and lack of from the political leaders to actually put in place an effective framework. The reality is true, as you have said. The majority of national health insurance financing actually goes to the private sector. There has been efforts to enhance the controls of NHIF, for example, through change in the law to ensure that there's equity in relation to how it disburses to private vis-a-vis public. How that is going to be implemented is a different story that we will wait to see how effective the law will be implemented to ensure equity in relation to access. But if we are going to enhance people's ability to enjoy their health, private insurance is not the way to go. Even if it's controlled by the public sector, it's not the way to go. We have to invest in our public healthcare system, and we have to make sure that people have access, that we have the infrastructure that enables people to have access to these public healthcare systems. If we have a well-functioning public healthcare system, we wouldn't need to go to the private sector, and that will ensure that even the private sector is then able to put in place effective mechanisms for service delivery that is not too costly and that ensures that there is quality in the work that they, in the service that they offer in that context. So for me, private health insurance, even if it's run by the public like the NHIF, is not the solution for effective healthcare infrastructure. We need to invest in our public healthcare systems. In relation to accountability, for financial institutions, we had this discussion with the IFC, and we had this discussion also with USAID in the context of their financing of private healthcare in Kenya. And I know USAID is in the process of developing an accountability framework. We tried to ask them the parameters of these accountability frameworks that will ensure that those private health entities that they finance do not actually engage in practices that are contrary to the national health objectives. But we were not given that response up to now. So it's a question I am not capable of substantively answering, but I think it's important for us to focus and put them into account to ensure that for the finances that they provide, they should be able to hold the private entities that receive those finances accountable. Thank you so much.
Thank you so much, Nicholas. You'll notice that I've taken to just using first names. One, because I do not want to increase my chances of getting people's names wrong by mentioning the full name, and also because we are among friends, we're having, cozy discussions here, so I think it should be fine. So thank you so much, Nicholas, for your presentation and for taking part in the Q&A. We'll understand if you need to drop off at some point. So right now we'll have Mrs. Perpetual Ofori Ampofo to speak to us. She's a Deputy Chief Health Tutor at the Nursing and Midwifery Training College at Kolebu here in Ghana under the Ministry of Health. She has a master's in public health and a Bachelor of Arts degree in nursing and psychology from the University of Ghana, where I also am. And she has a postgraduate diploma in education from the University of Cape Coast. She is with the Ghana Registered Nurses and Midwifery Association. And I see from the program that she's the chair of WAHUSN, which I tried to look up, but I couldn't find. So perhaps before she gives us her presentation on healthcare campaigns in West Africa for 15 minutes, she can tell us what that acronym stands for. So Perpetual, over to you.
Thank you so much, Nana. And I bring you all greetings from Ghana. And I want to thank the organizers for giving me the opportunity to share to highlight some issues on the healthcare campaigns in West Africa. So just like Nana said, I'm Perpetual Ampofo. I'm the president of the Ghana Registered Nurses and Midwives Association and also the chair for the West African Health Sector Unions Network, which is shortened as WAHUSN, that is WAHSUN. So I'm happy to be here this afternoon and to share some light on the healthcare campaigns in West Africa. So as the chair of the West African Health Sector Unions Network, which has been in existence for close to 13 years. We have been able to achieve a lot. And I must say that the network launched its Health for All in West Africa campaign in April of 2018. And I should have said earlier, the network is under the Public Services International. And I guess we all know what Public Services International is. And as part of that launch, the launch actually formed part of the 10th anniversary of the network. And the objective was to draw the attention of West African governments to the need to prioritize health and adhere to the Abuja Declaration of committing 15% of the national budget to health. We have heard from Nicholas, who gave a fantastic overview of healthcare situation in Africa. And indeed, if governments or countries within the region were committing up to at least the 15%, we would have had enough going on in the health sector to be able to provide adequate public health services to all the populations within the sub-region. And of course, if we are able to also commit these budgetary allocations, we would be able to achieve universal health coverage and the Sustainable Development Goal 3 by 2030. And we are already in 2022, and we have just about 80 years to go in terms of ensuring that we attain these the targets of these momentous objectives. So it is the onus lies on all of us, and especially for we as trade unions. It is important to us because within the health sector, we have seen a lot pre-COVID and post within COVID, and even as the numbers go down within this time, we are also seeing a lot. And COVID has taught us a lot of lessons that we cannot afford to adhere to and ensure that in the years ahead, we do the right thing as nations. I must say that as part of that campaign in Abuja, we also submitted a paper to the West African Health Organization office in Abuja, and it allowed us the opportunity to also open some engagements and links with that entity. And OTUA, which is the Organization for Trade Unions in West Africa, also launched its Health is a Human Rights campaign, and in collaboration with other organizations, calling on West African governments to invest more in healthcare, especially for informal sector workers and their families, including the provision of adequate hospitals and clinics in marginalized communities. And based on the overview that Nicholas gave, we know that as soon as you move from cities to districts to the very basic levels of our societies, the very communities, you realize that access to healthcare is very difficult. And where there is healthcare, you may need to have enough money to take care of your needs. And you realize that when it comes to informal workers and what they do, enough money is not generated, and therefore access to healthcare becomes very, very difficult. This campaign by OTUA has been extended to the West African Health Sector Unions Network, and it involves health sector unions, trade unions who have taken this campaign up and are also through various activities letting our governments within the region understand that health is indeed a human right, and we must put in all the investment that is required in health to ensure that we build our public health systems in such a way that health becomes very affordable and nobody is denied of healthcare because that person does not have money. So this campaign is ongoing in a number of countries, including Ghana, Nigeria, Liberia, and others. And we intend to continue on this tangent to ensure that we engage the various ministries of health, if need be, visit the seats of government to talk about these matters and use our parliamentary representatives and the caucus on health issues to also push this agenda. We have also, through the Public Services International, been on a campaign for the TRIPS waiver. In this COVID, we saw vaccine apartheid and the fact that we could not access vaccines, especially within our region. And it became important that we all add our voice to it so that the patents on these vaccines are waived by the World Trade Organization so that other countries can actually produce these vaccines, which will be at a cheaper cost and allow more people to have access to these vaccines and be vaccinated. So we have moved from this TRIPS waiver to a point where the pandemic treaty is also being developed, and a lot of discussions have gone on, a lot of negotiations, and through the Public Services International, to their support, our voices on the COVID-19 pandemic as health sector unions are being heard. And our belief as health sector unions or workers is that our experience and perspectives must be heard and must be at the heart of the process of the pandemic treaty. And based on that, we are calling for the need to hold people over profits. We as people and as workers and as citizens, our needs should override the profits that will be made by the big pharma institutions or entities. And we are demanding the incorporation of universal public health care. That is 1. 2, better staffing and better conditions of service. 3, stronger health stockpiles and supply chains. 4, suspending patents on life-saving supplies and medications. And 5, reshaping the global economy to serve health outcomes. We are calling for the incorporation of these to be in the heart of this pandemic treaty, so that at the end of the day, we can build stronger healthcare systems across our nations. Among health sector unions, we are also campaigning on the need to turn our attention to the mental health situation of healthcare workers. It will interest you to note that suicide rates have increased among health sector workers because of the many emotions and experiences that we have gone through within this COVID-19 pandemic. We have seen a lot of deaths, among our own colleagues, deaths among the public, and decisions that were taken at one point or the other that as healthcare workers we felt could have been better. And all these things have affected the mental health situation of many healthcare workers, resulting in attempted suicides. And at this time, we are calling for more attention by governments and all entities or all stakeholders to be turned to healthcare workers. There's a need to have breaks so that people are not actually swallowed in the work that we are doing, and to be able to rest, get some form of counseling at one point or the other, to be able to provide better services to the public. And most of the time, because we are healthcare workers, sometimes we are looked at and believed to know it all and to be able to take very good care of ourselves. But sometimes that is not the case. We also need help at one point or the other. And that is the call on this campaign. So we have made some gains on these campaigns that I've already mentioned. And it has led to a lot of engagements with stakeholders and those who matter when it comes to policy. And in some cases, it has resulted in the increased allocation of funds to the health sector. And in Ghana, for example, Agenda 111 was launched by the government to build a number of hospitals in a number of districts, refurbish mental health facilities, and also improve on existing teaching hospitals and the like. So these are some of the achievements, and we are hoping that as we even engage at this time, our voices can all lead to the call on our governments to increase investment in health, so that we can actually build the capacity of our health sector to be able to provide the required services for our citizens. It is not enough for example, for politicians to move outside of our countries to seek medical help elsewhere, when for ordinary citizens, we are left to our fate in terms of whatever public services that are available to us. And it's important that we build our healthcare systems so that there's no need for any high-profile person to travel to Western countries to seek medical help. They will be proud as leaders in our various countries to seek medical help from our own institutions and from our health workers within our jurisdictions. And I would like to conclude by saying that health is indeed essential foundation for the long-term development of our economies and societies, and campaigns in all forms, whether it is virtual or in person or in whatever format, should be intensified to sustain the gains and also to improve the momentum and the call on governments to ensure that we invest in health and improve our public health systems. At the same time, find modalities to also help the private sector to also improve. Thank you very much for listening, and thank you for the opportunity.
Thank you so much, Perpetual. Thank you. And I assume that everybody else, all the other speakers, can stay on till the end when we have a fuller discussion. So I will point you, Perpetual, and other speakers to the questions that are coming up in the chat. So please take the opportunity to read them so that you can prepare to speak to them. You might also choose to respond to them in the chats. That would also be a great way to save time and engender discussion in the chat as well. But thank you. I'm going to go straight away to Dr. Bernadette O'Hare, who's a senior lecturer in global health at the University of St. Andrews. And she's also a senior lecturer in global health, again, at Kamuzu University of Health Sciences in Malawi, as well as a consultant pediatrician. There are a lot of things that I could say about her, but for the purposes of this panel, I find particularly interesting the way that she integrates advocacy into her research work, how she straddles those two worlds. So I just want to quickly mention that as a member of the Scottish Global Health Coordination Unit, she initiated the active global citizenship strand of work within that association or within that unit, and is currently the lead champion of academia. She also formerly sat on the advocacy committee and the international board of the Royal College of Pediatrics and Child Health in the UK, and also the Pediatric and Child Health Executive Committee in Malawi. So Bernadette, over to you now.
Thank you very much. I'm hoping everyone can see my screen.
Yes, we can.
And hear me okay?
Very well.
Yeah, thank you very much for that very nice introduction. And I'm really honored to be on this panel. And having, I've worked in Africa for about 10 years, so I'm delighted to be here, and I'm passionate about what we're discussing this afternoon. So what I'm going to discuss is tax gaps and the Sustainable Development Goals. And when I use the term Sustainable Development Goals, I remember that the SDGs are grounded in international human rights. And of course, the right to health is one of those rights. And as we know, and we've heard all of this week, we are all experiencing overlapping crises, and many of them are human-made. And we include the debt crisis, the climate emergency, the war. And to quote the Vice President of Malawi, who said, COVID-19 did not create the development finance challenge in Africa, it just exacerbated it. So there is already limited fiscal space in government's budgets for human rights currently, for their current human rights obligations, including the right to the determinants of health, without additional challenges. And when I speak of the determinants of health, I think of particularly the critical determinants, the physiological determinants of health, including water and sanitation, as well as education. We know that it's a very important determinant of child health, that mothers are educated. So this is just to show us, to focus in on government revenue and to think about what would increase government revenue, because maybe if we could increase it, we could increase government spending and increase access to fundamental rights or public services. And just to remind us, 75–80% of government revenue comes from taxes, and that includes both domestic and international corporate tax. And in order to increase that pie, we would have to change tax administration, change tax policies, and sometimes to change these things can take quite a long time. They can be quite political, quite difficult. They can also be either progressive or regressive. We know that if we increase value-added tax, that we may in fact harm the people that we wish to help by increasing the cost of food. So while we might increase VAT to improve healthcare, we may be compromising a family's ability to eat nutritious food. In terms of international corporate tax, corporations makes huge contribution to the public finances in many countries and is critically important. In fact, it's actually twice as important in lower income countries than it is in higher income countries. Mainly because there's a narrow tax base and there's a large sort of informal economy. So international corporate tax is very important. Therefore, whenever international corporate tax is avoided, that is also very important, particularly in low-income countries. And there's no doubt that if international corporations avoid tax, it'll compromise government spending, it'll compromise public services, it will slow progress to the Sustainable Development Goals, and it will have a negative impact on human rights. Now, revenue is important not just from the perspective of revenue itself to fund things, it is also important from a number of other aspects, and redistribution is critical. If a government uses their tax to ensure that those most marginalized in society have better access to public services, this improves health of the population. It also is a tool in terms of health for repricing. We can have tobacco taxation, alcohol taxation, taxation on carbon emissions, and on highly processed or sugary food, all to improve healthcare, to improve health. Representation is probably the most important. We know that the reliance on government spending on tax revenues is strongly linked to governance. And we mustn't forget this really important link. And when we have improved governance, it helps economies to grow. Better allocation decisions are made, and we've discussed the Abuja Declaration and the allocation to healthcare. And spending is more efficient, and we've already discussed the reliance of many families on out-of-pocket care, which means they have to divert money from other important needs. So governance is really important. And sometimes we hear that it's okay to avoid tax because it won't be used well. Governments won't use the tax well, and that's okay then. But actually, we've recently showed with the University of Leicester that as governments get more revenue, it actually improves governance and all of the other effects that we see in this diagram. So this is a good counter to the argument that it's okay to do aggressive tax planning or avoid tax, that's okay because it wouldn't be used properly. That's not the case. And just if we have a little look at this slide, along the bottom is the revenue per capita, and this is from cross-country data over many decades. And we see that as government revenue per capita increases, access, this is coverage, and I've used basic water because it's such an important determinant of health. Access to water increases. So when we have more government revenue, more people have access to basic water access within 30 minutes of the home. And at low levels of government revenue per capita, even small volumes, and I'm just looking at the dotted line right now, even tiny volumes of increased revenue can have a very significant impact. So the message here is that no matter how small the increase is, it could be very important in some places, in some countries, and it could be very important to some individual people. So government revenue is important. This line is when there's sort of poor governance, and there we see, and this is no surprise, that an increase in revenue has less impact. So more revenue and better governance has a really powerful effect. So this leads us to the next question, which is, where do we lose revenue from? And, you know, lots has been written on this, but the big ones are tax losses. And we know that when governments don't have an adequate capital, they do have to take out debt to cover their expenditures. And the problem with debt is not so much we often see it expressed as a percentage of GDP, but the important thing is how much of government revenue is being spent servicing that debt. And as we all know, some debt is very good. It's used for productive purposes. It can be used for human capital, which will have payback dividends, but some of it is not used for those purposes. So tax losses is associated with increase in debt, and all of this will impact public services and the SDGs. Tax losses can be either, as mentioned, domestic or international. And the domestic losses that we've seen, we've heard a lot about, are tax exemptions. And this includes granting large exemptions to some companies without clear evidence of benefit. And lots of people here in this room has written about this. We know that when debt service becomes unsustainable, it often results in a restructuring of debt and austerity, and this also negatively impacts government spending, public services, and human rights. And this slide is just to show us that revenue losses from, I'm going to look at the international side of things, revenue loss to international corporate tax avoidance in low-income countries actually is larger than the domestic government health expenditure. And we've just seen earlier on already today how small domestic government health expenditure is in many countries. And that gap has to be filled by families. And this is just from the same source, which shows in some countries there's quite a marked difference. And it's in those countries that we can sort of start to really ask the question, why are we losing so much in these countries? Is there anything that can be done to curtail these losses so that there's more to spend on public services? And this slide is just to show us, it's a modeling that we've done with econometricians that shows whenever government revenue increases, it does impact health. It impacts the determinants of health, and it impacts survival. And for example, this is a case study of Zambia, and using the most recent state of tax justice estimates on international tax abuse and tax evasion. And it's just projected over 10 years, because of course these problems don't happen one year, they happen over decades. And the effect is cumulative over decades. And we can see on the graphs that if this particular country had more revenue, hundreds of thousands of people would have access to their fundamental rights. Thousands of children would survive and hundreds of mothers would survive. So this is important. It's important for those of us who care about health. It's important for healthcare workers. And we've heard already that Africa is a net sort of creditor to the rest of the world. And this is just to show this, and looking at this is expressed as a percentage of government revenue on the vertical axis. And the blue is tax abuse using the 2021 figures as a percentage of government revenue. And it looks quite small. But when we look at the effect, the addition of debt, it's actually adding up quite a bit. And if we look at the slide on the right, we can see that in fact, it's quite substantial. In some countries, it's very substantial. So this is an important issue that we we can work on together, and we must focus, because it does cause a problem for health. And this is just a slide really to emphasize what we already know, is that these losses far outweigh any gain in terms of overseas development aid. And this is from the members of the Development Assistance Committee. So it's really important that we focus on domestic resource mobilization. This is a slide taken from the Debt Justice Campaign, who have said that whenever losses exceeds 15%, it leads to a decline in government spending. So these countries in orange or red, in fact, have losses of more than 15%. So then we get to sort of start thinking about, well, what can be done? You know, what can we do collectively about this problem? And the most recent report by PSI and the Global Action for Tax Justice and the Tax Justice Network identified 4 countries really as the countries whose rules and regulations created the vulnerabilities to most global tax abuse. And you can see the countries there: UK and their dependent territories, Luxembourg, Netherlands, and Switzerland. So these are the countries whose rules, if they were to change, maybe we could have a change in the amount of spending on public services and human rights. And this has been brought to the attention of international human rights committees. And for example, CEDAW, the Committee on the Elimination of Discrimination Against Women, has stated the state's party, and this is talking about the UK, financial secrecy, legislation on corporate reporting, and taxation practices might have an adverse impact on the ability of other states, in particularly those already short of revenue, to mobilize maximum resources for the realization of women's rights. And more recently this year, the Committee on the Rights of the Child, the UNCRC, asked the Netherlands, one of those countries, to conduct independent and participatory assessments of its tax and financial policies to ensure they do not contribute to tax abuse by national companies operating outside their country that might lead to a negative impact on the availability of resources for the realization of children's rights in the countries that they're operating. So these are very strong statements to support this sentiment. An even more sort of broader approach has been taken right back in 2015 when the Mbeki report, the landmark report on the high-level panel of illicit financial flows from Africa, stated that the UN processes and frameworks would be the ideal forum for international tax coordination. So Africa already was shown leadership quite some time ago in this arena. And then more recently, we've heard one of the key recommendations from the FACTI panel is creation of a fair mechanism to arbitrate international tax disputes under a UN tax convention. And if anyone is interested in reading more about this, and particularly in reading which countries support this and which countries don't support it, there's this fantastic database. I've put a link to it, and it gives the history going right back to 2011, when different groups of countries have been calling for a move in this general direction. And this is one just in 2021 from the G77. And I've just put up some pictures, calls for the Committee of Experts on International Corporation Tax to be accorded the status of a UN intergovernmental body with experts representing their respective government. So this call has been made. This is a vote, and I've given the link there, and many countries supported it, but some countries didn't support it. And I think that's where we need to sort of think. I mean, we know that illicit financial flows, tax abuse compromises government spending on the right to health. And it would be good to understand why all countries wouldn't support such an important move towards human rights, particularly when all countries have signed or ratified are signatories of the UNCRC. All but one has ratified it. So it would be important for us to think why that might be. Finally, last year, or this year, sorry, this is a quote from ECOSOC. The African group strongly believe on the urgent need to establish universal UN intergovernmental tax body and negotiate a UN tax convention to address all of the problems that lead to lost revenues. We believe, and this is the hopeful part, I think, that if implemented, there is the potential to significantly reduce existing structures that make it impossible for governments to generate and retain a sizable chunk of their resources. So just to summarize, government revenue is critical, state building is critical. For states to be strong, they need to have money to go about their business. For health advocates, it's important that we join hands and advocate against losses from these budgets. And it's also important to remember that more revenue will actually increase governance and lead to a virtual circle and lead to all the good things that we all wish for all people. What narrative? So I guess I think the important narrative is the one I've just been talking about. Who should lead it? It should be the Global South, and they already have. The role of the Global North is to call on our governments to support their calls, and to provide whatever evidence and support we can to move this agenda along. So thank you very much for your time.
Thank you very much, Bernadette, for that. Again, I'm encouraging you to, the audience, I mean, to put your comments or your questions in the chat, and we'll look at all of them afterwards. But again, have these parallel conversations even as we go on to the last two presentations. So the next one is by Anna Mariott, who is a public services policy manager for Oxfam, Great Britain, and is health policy lead for Oxfam International. She's led Oxfam's work on universal health coverage for the last 10 years and has published several papers on health financing and healthcare delivery, including on the risks of the increased influence of commercial actors in national health systems in the global South. I see also from her, the name she's put under her picture in the video is that she is with the Global People's Vaccine Alliance. So Anna, you have 15 minutes to talk to us about the IFC and financialization in healthcare.
Thank you so much, Nana. And just to echo my thanks to all the organizers and all the previous speakers as well for a fascinating session. I'm not intending to use my 15 minutes slot today because I want to give more time to Al-Hassan, who will follow after me. And my intention of speaking today was really just to provide some kind of historical context to what I think Al-Hassan will be talking about in terms of the present day situation of financialization of healthcare in Africa today. And so what I wanted to touch on briefly is to flag an institution who we at Oxfam, and I know many of you believe, have played a pivotal role in building a narrative in favor of a greater role for the private sector in African healthcare, but has also itself been a driver of the financialization of healthcare in Africa via its own investments. And that, as Nana said, is the International Finance Corporation, the private sector investment arm of the World Bank Group. And looking back in 2007, the IFC, supported by the Bill and Melinda Gates Foundation and McKinsey, published a report called The Business of Health in Africa. The report purposefully and misleadingly lumped all non-state healthcare provision together in Africa, from corporate hospital chains to religious providers to unqualified informal drug sellers to not-for-profit providers, to make the claim that the private sector already provided half of all healthcare in Africa and a higher proportion than this to the poorest people on the continent. And you know, the theme of this whole conference is about narratives in public services, and I think that this report itself is a masterclass in narrative setting. It's full of the usual misleading claims about the superior efficiency, reach, quality of the private healthcare sector, and you know, was a real rallying cry for greater support for the private sector, yes, to improve quality and regulation, well, actually less on regulation, but was really calling for an enhanced role for the private sector in African healthcare systems going forward. Not just, you know, as the historical argument had been, by keeping the state small and allowing the private sector and the market to prevail in the provision of public services, in this case healthcare, but actually active support from the public sector via health insurance schemes and via public-private partnerships. So I refer back to what now is quite an old report from 2007 as really quite a seminal narrative in the extent of financialization that we're seeing today, not just in Africa, of course, but across many continents. And just after that year, in 2008, the IFC launched the Health in Africa initiative. This is a $1 billion investment project, $1 billion investment project, which aimed, and I quote, to catalyze sustained improvements in access to quality health-related goods and services in Africa and financial protection against the impoverishing effects of illness. And it made, you know, specific reference and emphasis on the underserved. And the plan was to achieve these objectives by harnessing the potential of the private healthcare sector, specifically by improving access to capital for private healthcare companies, enabling them to grow and expand, and through assisting governments to incorporate the private sector more and more into their overall healthcare system. So this was the aim, and again, the emphasis was that this initiative would take extra efforts to improve the availability of healthcare to Africa's poor and rural populations. In terms of how this was then operationalized, it aimed to generate this $1 billion fund via three main investment mechanisms: a $300 million equity vehicle, a $500 million debt facility, and by mobilizing loans from local banks to private healthcare actors, and a $200 million fund for technical assistance. And this technical assistance you know, was geared around this reorientation of healthcare systems to incorporate these private actors into African healthcare systems. So there were two main private equity funds launched or invested in by the IFC. One was the Africa Health Fund, which was managed by the Abraj Group, which infamously imploded due to a massive corruption scandal just a few years ago and was taken over by another investment fund. And the second was called the Investment Fund for Health in Africa. And this was established and managed by the Dutch Farm Access Foundation. Now, both of these funds have been successful in crowding in the support of other development finance institutions, as well as the Bill and Melinda Gates Foundation. There's a theme here. But European development institutions, the African Development Bank, have all kind of joined hands with the IFC in investing this publicly backed finance into these investment funds, which then go on to invest in private healthcare companies operational across the continent. So the IFC was successful in terms of crowding in this support. And I would say that it was also successful in ensuring that its narrative in this Business for Health in Africa report became the mainstream narrative, and not, a few years later we saw the Financing for Development Summit in 2015 really adopting the same kind of language about the importance of blending public and private financing. And then this evolved in 2017 into the World Bank adopting its maximizing financing for development approach, which, at its heart is about prioritizing private financing options before public financing options. So if we can fund things privately, let's do it that way. Let's remove all the risk for private investors. Let's reshape our economies. Let's do it, whatever it takes to crowd in that private investment. And only as a very last resort would we take the public option. So then just looking back again, just a year after the IFC launched this massive 1 billion fund, an independent evaluation of the IFC's previous decade of investments launched a scathing report saying that the IFC had failed to monitor its own performance, that the healthcare facilities it was investing in were serving upper and middle income people. Many of its projects had collapsed, were not cost effective, and the majority failed to meet minimum expected outputs. But the review was too late. It was ignored, and I think the IFC's Trojan horse of investments and its narrative had already made such an impression that this evaluation of the IFC's lamentable performance in health was able to be overlooked. And then a few years later, another independent midterm review of the IFC's health in Africa was equally critical, said that there were systemic failures of the IFC to monitor or evaluate its contribution to pro-poor healthcare access, to even engage in the most controversial question around the role of the private sector as to whether it actually does do any benefit or give any benefit in terms of progress towards healthcare for all. And the IFC was simply ignoring the impact of its investments in progressing the universal health coverage agenda. So in 2014, Oxfam did an analysis of all of IFC's investments in African healthcare, and I'll just summarize a couple of the findings. But the most important was that our findings echoed this midterm review and the IFC's and the World Bank's own independent evaluation of the IFC, that the vast majority of the IFC's investments were going towards expensive elitist hospitals serving Africa's wealthiest populations, as well as expatriates. So this wasn't about progressing universal health coverage. This was about pro-rich elitist healthcare, and the IFC effectively enabling profiteering by investors and corporations within Africa's healthcare systems. I'll give one example. The Nairobi Women's Hospital in Kenya continues to be a recipient of Development Finance Institute's investments, including from the IFC. This hospital has been marked by scandal after scandal of patients imprisoned in the hospital for not being able to pay their bills, the bodies of loved ones locked up, again, for not being able to pay their healthcare bills. We found that at the time that the cost of the most basic maternity package at this hospital was the equivalent of 3 to 6 months' wages of the average Kenyan woman at the time. But we've also seen, other investments by the IFC in elite hospitals in Togo, Chad, Nigeria, South Africa, and across the continent. And far from supporting small and medium African private healthcare operators, we've seen that the IFC has backed some of the largest hospital chains, including in countries like South Africa, that really don't need the backing of a development finance institute whose mandate is supposed to be about poverty reduction and tackling inequality. So that research is now dated, which is why I want to hand over to Al-Hassan today to give us a more up-to-date contemporary picture of the financialization of healthcare in Africa. I'd point you to some more recent research that's been conducted by an organization, by the organization WEMOS, on the IFC, and to Susan Engel's work on behalf of Public Services International, also monitoring and mapping what the development finance institutions are doing. And just my final comment before handing over to Al-Hassan is that I guess it's a plea that I think we all need to be very wary of the role that these external so-called development actors are playing in driving a privatization, commercialization, financialization agenda in the African continent, and that we need to hold them account, as well as obviously our local and national governments. And I think also to be incredibly wary of their agendas. So my more recent research has looked at the European development finance institutions, including my own government's development finance institution, previously called the CDC. And I would say that these governments are being much more brazen about using their development finance now for their own national commercial interests. So we're seeing a narrative emerging that justifies development based on the fact that it's in the interests of finance as well as commercial interests, with links to the UK government, to the UK economy, for example, and that this isn't just about ideology. This is actually some powerful drivers pushing this agenda, so that the richest on the planet can extract even more wealth from African healthcare systems as well as from other continents. So just a plea to be wary, and would be really keen to join forces with anyone else that's interested in this agenda. But I'll stop there and hand over to Al-Hassan.
Thank you so much, Anna. And just before I quickly allow Al-Hassan to speak, I just want to introduce him briefly. Al-Hassan Adam researches public services and social movements with a focus on the continent of Africa. He joined the Public Services International Research Unit, PSIRU, in 2021, and he's an associate researcher there. He's also pursuing a PhD degree, so his research for his PhD is on drivers and approaches of private equity investment in global healthcare systems. And he's drawing on both his knowledge as researcher and practitioner to talk to us today about private capital in African healthcare. Al-Hassan.
Yeah, thank you, Anekia, for the introduction, and Anna for setting the scene. Really brilliant scene setting. And Oxfam's work is one of the cutting edge, I would say, in this field. And then I would urge Oxfam not to rest on their laurel and work more in the area, especially given what's happening now. So I would want to start by just throwing up this statistics from the World Health Organization's World Health Statistics 2022, which for me is a bit curious when you look at the countries that are financing heavily by their governments in health. Basically, when you look at it, the high income countries, about 70% of their health expenditure comes from their governments. And in low income countries, it's just a paltry of 27%. So there's something here, there's something happening here. Meanwhile, the people who come around to advise this government in low income countries is to advise them to rely on private sector to invest in the health sector. Meanwhile, in their country, that's not the scene. So they preach different gospel when they are in low income countries, and in their own countries, it's a different scene altogether. although there are people in the high income countries too who will be happy to see government slash their funding for the health system. But in reality, there's a lot of government financing of public health in high income countries. Now, my focus would be on private equity investment. This is a new vehicle for private investment in health globally, and they are making some inroads in Africa. And I would like to just give a quick definition of these guys, and then you see why, when we discuss later, why it's a problematic area that we need to focus our attention on. So private equity investment, they are organizations that are corporate in form, but have no public shareholders and are not listed on traded, unorganized stock exchanges. So basically, these guys are not regulated by the stock exchange. They are individual private companies raising money from their peers and from other people and from pension funds. We'll come to discuss that. And they have some 4 features which are a bit different from the usual private companies that we know. Apologies, the sound you are hearing at the background is my clock. It's a woodpecker. So don't get scared. One thing you need to know, this private equity are classified into 2 different groups. One group is the one that's referred to leverage buyouts companies. And with the leverage buyout companies, they go about raising money from other people, from pension funds and banks and others, to buy out companies outright sometimes. And then there's the other feature of private equity, which majority of you might heard of, which is the venture capital. And venture capital funds invest in new enterprises by providing financing and support that helps to scale up promising technologies and business ideas. And so venture capital, a lot of them invest in smaller companies, but they leverage buyouts target really big companies. And that's the 2 differentiations between these 2 forms of operations. But also, there are 2 power engines within the private equity. The first power base is limited partners. The limited partners are a group of second layers companies. They could be pension funds, like if you are a teacher, your teacher's pension fund will be run by another private company who would then lend money to a private equity. So the pension funds in this case are termed as institutional investors, or in short, LP, or limited partners. The limited partners, or the LPs, could also be insurance companies who have taken your insurance money, but they are looking for investment that will give them returns, so that when you have an accident or when you are sick, they'll be able to pay you your dividends. So insurance companies too could be limited partners in private equity funds. Now there's the other power engine, which is the general partners. And the general partners are the ones who set up the private equity firm and go around to the limited partners to raise money from the limited partners. So usually these general partners would also have a little bit of money. They just don't raise 100% money from others. They also have some money. So an example of a general partner would be Blackstone or BlackRock or CVC Capital. Warren Buffett also has another general partner company. Now, how did we come to this private equity funds? It started actually in the US, where businesses were getting worried that publicly registered companies on the stock exchange, the directors or managers are taking shareholders for granted and they are wasting shareholders' money. So there was a case in the 1980s, one of the celebrated cases of how public listed companies could waste shareholders' money. A chief executive of a company called Nabisco had a private jet for his pet. And this was like, kind of like, yeah, we need to invest now in private equity so that the managers would have a skin in the business and they will not waste our money like that. So basically when they say managers should have a skin in the business, is that the managers should also invest in the business and not just be paid their salaries and bonus. Now, other features of the private equity is that it allows them to exit when they want to. And then it allows them to raise money easily without going to too many regulatory frameworks for checks and balances. And there's a lot of person-to-person relationships, and it's open and transparent. Okay, so this is the settings. So let's see how the private equity, whether it's open and transparent. Anna mentioned Abraj. So Abraj was a company, a private equity company that was formed. Abraj raised $14 billion. And Abraj had an accounting firm, KPMG, as their kind of accountants and auditors and stuff. But Abraj also had a son of one of the KPMG's directors working in Abraj. So you see the relationship developing there. This guy, the Abraj guy, Arif, in the photo on my right, was a celebrity at the World Economic Forum because he was doing social enterprises as well. And health was the soft spot. He set up a $1 billion health fund. Bill and Melinda Gates contributed $100 million to that fund. And when the Bill and Melinda Gates $100 million hit the coffers, CDCs, which Anna mentioned already, IFC and Propaco from the French, they all pile in and contributed to this guy. And this guy used the money and lived his lavish life. He wasn't building the hospitals that he was building, and it became a big scandal. But because it's a private company, it's a private equity, and all these guys were involved, they managed to kind of make it hush-hush. The guy is living in London. He's been tagged. He cannot leave his house because there's a court case on him, and they've given him a tracker. So, but on 27th, this was the day that we started this conference, a court in Dubai fined him by the Dubai regulators for deception, for personally orchestrated deception. and the collapse of the 14 billion firm. So that's the story of private equity. Now, in Africa, there are all manner of private equity floating around, but I'll just highlight a few of them, and maybe you guys would know some of them. There's a funding or a kind of like general partner, I would put them in that way, the Investment Fund for Health in Africa. This fund has these hospitals in different countries and other operations, not necessarily hospitals. These are just examples. In Uganda, they have the Nakasero Hospital. In Kenya, they have the AR Hospital. And South Africa, Newberg Global Laboratories. And in Nigeria, Hajia Nigeria Limited. And again in Kenya, you have KPE Insurance Company. So you could see the investments are not just in one aspect of the health sector. It ranges from health insurance, care delivery, pharmaceuticals, and other operations, which I haven't mentioned here. Now, who are the supporters of this fund? And on my screen are the name of the supporters. But what for me is interesting is Aegon, which is an insurance company, Heineken, the brewers, Shell, Unilever, and then you have pension funds, Pfizer, IFC, Africa Development Bank, the Dutch European Investment Bank, the Swiss Investment Fund for Emerging Markets, name it. So these guys are using Africa as, at the moment, as a kind of laboratory to test private equity funds. They are big in Europe, big in America, emerging in Asia, but very insignificant in terms of the economy. But here, if you look at the operators, the money behind them, it means that they mean business. So what's the strategy for private equity? How do they get into a hospital or any facility they are interested in? And this is an
Al-hassan,
interview.
are you rounding up? Perhaps?
Yes, I am. And this is the key strategy. One of the private equity guys said that a key step when investing into research and development-based business is coming up with a valuation of how much the business will be worth in 3, 5, or 10 years. When valuing mature companies, more valuation methods are used, such as estimating future income streams, which are discounted appropriately for risk. So they are not coming into your hospital or health service delivery just because they want to promote the right to health. It's a business. So let's get it straight. So if your government are telling you that these guys are coming in to help solve health crisis and stuff, they're only coming in for a business. If it doesn't make business sense, they will not be there. Thank you. And we could have some conversations later.
Thank you. Thank you so much, Al-hassan, and thank you to everybody for leaving us enough time for conversation, for discussion, for comments, some of which have already started on the chat. We've traveled a very interesting road. We had Nicholas give us an overview of basically the state of healthcare in Africa, and then Perpetual talking to us from the perspective of, activists and advocates. And then we've had 3 presentations on the mechanics and, more importantly, the politics of financing of healthcare from a government perspective, taxes from the private sector, and then from these global financial institutions. So there's really a lot of rich material to get into discussions about. So I'm inviting people to raise their hands if they want to speak out their comments or questions. I'm not going to read all the comments in the chat because I think that's for all of us to engage with. But I did notice that Justice had raised specific questions. So I'm going to read that first. How do we fight the brain drain of nurses in Africa, especially where most economies in Africa cannot afford to compete against the salaries that they are offered in Europe? And secondly, has Africa learned and is it ready to stand and fight another pandemic of COVID proportions? That is the big question. I don't know which of the speakers want to take this one on, but I'm going to put that out there and maybe get a couple of other questions, and then I'll invite the speakers to come in and respond to those that they would like to. Amitabha, please go ahead and ask your question or make your comment.
Hi, thanks to all the panelists for this excellent presentations and exciting and enticing lectures. I'm sorry, I'm not from Africa region, actually from Asia, India. But I recently finished my PhD on IFI and health, and thought that some concerns to share over, so that maybe the current panelists may further reflect upon. I just see one point is that what I found in my own research, actually, be it in Africa, Asia, even Latin America, the entire USC movement, universal health coverage movement, and especially in emerging economies, including some of the countries in Africa, where this publicly financed health insurance, that is, of course, pushing more towards privatization. And here the interesting point is that the development financing institutes, they have been come upon heavily. And in fact, the financialization, the entire discourse for financialization, especially in health, more or less also speeding up post 2010, which is also a birth of universal health coverage. Now, my question to the panelists is that there are ample evidence, even the Anna's work on Lesotho in Africa, the Oxfam work, so where the violations on patient rights, violations of overall people's health had happened and has been happening. So mostly these are under, say, the IFC's work or other development financing institutes. So they are actually under the UN umbrella, apart from the private financing institutes. So there are is there any precedent so far in Africa region where those institutes are being brought under the UN guiding principles of human rights and business, like the Rouges framework? Then please share some of them. And the second point is that it is, growing. There's a growing tendency of this channelizing or repurposing development financing for commercial investment. Say World Bank Group 2017 onwards at the private sector window, where now IFC is also drawing IDA money. IDA finance in developing countries. So this repurposing development finance for commercial investment is happening, whereas there is no public interference on behalf of the government. Be it in, I recently finished a work for Oxfam India on IFC in private healthcare. So, and also in Africa and other parts of the world also, that IFC, while IFC is financing, mostly they are actually in collaboration with the respective corporates, and there is almost zero interference from the government side, for the public side. So that's why the equitable investment where the healthcare or hospital infrastructures are necessary, it's really beyond the question. So can there be a framework at the country level where the development financing should be stopped for commercial investment, which is right now going on, and obviously it will be spearheading in the coming years? Thank you. Thanks to all.
Thank you, Amataba. I'm going to just ask the panelists to respond to Justin and Amataba's questions. You don't have to respond to every question. So whatever you want to speak to, as well as anything in the comments that you want to reflect on or respond to.
Okay, so
Okay.
On the Amataba's question in terms of national framework and stuff like that. For me, people keep saying IFC, IFC. The thing is, IFC is there to promote private. That's its mandate. So what you could do is to get rid of IFC. So long as IFC exists, that's their mandate. If we don't get rid of IFC, they'll keep doing that. That's their mandate. So it's for people to make sure that their governments don't put money into IFC coffers. That's where the problem starts. So long as they have the money, they would want to justify their mandate and they would like to spend it on private initiatives. So that's for me where the problem is. Try to stop IFC from being IFC. If you can't stop it, it will keep going. So for me, that's my response on the question of IFC. But the World Bank as an institution is supposed to be a public institution, supposed to be pro-public, but sometimes can be against the public in a number of ways. But if you put pressure on them, you can reverse it. And we've done it in Ghana in a couple of programs, from water to other social programs that we push the World Bank and reverse their position.
Perpetual, did you want to say something?
Yes, thank you, Nanaya. I just wanted to put in something about the question on nurses, the brain drain, and how Africa can work around it. The issue is that migration is a right, and people will tend to move across borders anytime, any day. It didn't start now, it's been there since time immemorial. But the point is, pre-COVID, the aging populations in the Europes and other countries, and the fact that there were existing conditions of service that were not good, served as pull factors for nurses in Africa, and especially within our region, West Africa, to move. Within COVID, we have seen a lot of resignations by nurses because of the impact of the experience of COVID, and some have abandoned their jobs altogether. So there is a wide staffing gaps in these health institutions across the Europes, Canada and America and the rest. And there is a huge opportunity for employment. And therefore what is happening is individuals are moving on their own. Some are moving through agencies, and some countries have gone into bilateral agreements with these other nations in the West to have their nurses move. The perception out there is that we have enough of these professionals within our various countries. But the truth of the matter is that when you look at the various qualifications and the kind of specialties these nurses possess, then you begin to realize that in country or domestically, we do not have enough of these to even serve our own needs. And therefore, if nurses continue to move at the rate they are doing now to other jurisdictions, we might have a problem in the near future. What we can console ourselves with is the fact that we have opportunity to train more, and the difficulty then becomes, you train them, can you retain them? Because the opportunities out there will push them to leave. And the local or domestic issues become the push factors, because conditions of service are not too good, salaries are low, and all of that. And therefore, people would want to move. But let us look at all that we've talked about today, it's all geared towards improving the health sectors of our economies within Africa. If we can get our governments to invest more, invest in education of nurses, and also focus more on specialization of these professionals, then we can actually have more of these professionals to serve our local needs, and also those who may be interested in traveling abroad to work can also have that opportunity. And even countries that are looking at exporting nurses, if I should use that word, in all these bilateral agreements can be comfortable knowing that we still have enough to serve our own needs. But beyond the education, we need to improve conditions of service of our professionals, better salaries, better working environments, availability of equipment to work with, logistics needed must be available, HR systems that are operating must be friendly to allow people to further their education, get promoted, and all of that. These are all the issues that sometimes push people away. And if we are able to strengthen or do better in terms of these, I'm sure we'll be able to retain our nurses in Africa. Thank you.
Thank you, Perpetual.
If I can comment on Amitabh's comment question. So, I mean, I think that using the UN Business of Human Rights framework is one useful approach. I honestly think that that what is required is the power of organisation on this. I think that there is enough evidence out there about the types of investments that are being made by the IFC and other development finance institutions in African healthcare systems, as well as Indian and other countries, to know that these companies, many of these companies are no good or abuse people, or, you know, there's evidence of exploitation, overcharging. Yes, we can always do with more evidence, but I really do think that there is there would be great progress made if we joined forces more in influencing the bank. And I say that because I know that our allies in education have achieved some quite remarkable things in terms of their campaigning for a divestment campaign from the IFC from private education, particularly with an emphasis on the likes of Bridge Academies, which Linda, who is in the discussion today, was very much involved in. And I think what they did was work together across countries, brought evidence of the IFC investments in different private schools, showed that those private schools were inequitable, excluding people, were not progressing the education for all agenda, and took that evidence to the decision holders, both at the bank but also with their governments. And I think that has to be the route through which we pressure for change. And I particularly feel that there is a very strong case to be made. You know, whether or not the IFC continues to exist, as Al-Hassan has said, that it doesn't play a role in public services, and at a very minimum, and certainly not in healthcare provision or private health insurance schemes. There can be no justification for that, particularly given their track record. So I do think that it would be important to organise ourselves and to work together with that agenda in mind, and to learn from the successes of our allies in education and other sectors like water, as Al-Hassan has said. I think, you know, that's not going to solve everything, and I think that we also need to be really cognizant of all forms of public subsidy being given to these private healthcare providers, whether that be through national health insurance schemes, exploitation of those schemes, as others have mentioned, through tax breaks, through free or cheap land for these corporate hospitals to build on. you know, all those forms of taxpayer subsidy should be scrutinized, and these private corporations held to account. So I think, you know, we have to be strategic, we have to work together, and we have to bring the evidence and the voices of those affected by these investments to the very top, and hold those accountable who are supposedly doing this in the name of development. Thank you.
Okay. Thank you. We've come to 3:30, and I'd like to be responsible and end on the time that we were given, but I will give Bernadette the last and brief word if she'd like it.
Thank you, I'm very honored. I guess as everyone's talking, I'm thinking these problems, you know, I suppose they will always be with us. You know, the private provision of healthcare, private equity, out of pocket will always be there until, you know, the governments become stronger and are able to fund this. And I suppose that's the background to my interest in this. And I think it'll be very hard without addressing the fundamental problem, which is there isn't enough revenue. And that's not to say that all of us don't keep working in you know, every tier that we're involved in, because it's all critical, while at the same time keeping an eye to the global economic system, which is causing these problems, if we want to address the fundamental problem.
Thank you. I really would like to thank all of our speakers and the audience. This has been a very fascinating panel, straddling research and advocacy and practice. In Bernadette's case, she does all three, but it's been the kind of conversations that we need to have if we want to move things forward. Whether to actually bring down institutions wholly, as Al-Hassan is recommending, or to try and shape them so that they are more useful to our well-being as, you know, as a global society. So thank you all. I'd like to also thank Vera for getting us all together and keeping us on track with her emails and reminders. And I'll turn back to her if she has any, you know, sort of announcements for us as we end.
Yeah, just to also say thank you, everybody. It was really inspiring. I learned a lot. Like, I feel my brain expanded today, which was really good. I just put in the chat the Zoom link for the Latin American panel in case anyone is interested, because it's, the first session will end soon. There are 2 more to come.
Vera, we are losing you a little bit.
Oh
we
my
can't
God,
hear
it's
very
my mic. I'm so sorry. I just said in the chat, I put in the Zoom link for the other Latin American channel. There are 2 more workshops on Latin America. So if anyone is interested to join, please join us on there. And tomorrow we have a really exciting program with final speakers, keynote speakers, and also ways to go ahead. So yeah, please come back tomorrow. And yeah, just exchange email addresses, stay in touch. It's a networking conference. Hopefully this is only a start of many, many more exciting collaborations. So thank you all for really great presentations and fantastic facilitation. Thank you. Bye-bye, everybody.